Well, welcome everyone and good morning to you. We're going to start in just a few moments here while we let people gather and come into this exciting Grand Rounds lecture for today. And I see we have a number of people joining us here. We are quickly filling up. I love seeing the numbers just jump up exponentially. We've gone from 40 to 56. We'll wait another few moments here. Okay. All right, people continue to file in. We're over 60 folks signed in now, so I think we'll go ahead and get started. So good morning, everyone, and welcome to you. My name is Dr. Michael Grote. I am the Chief Clinical Officer here at Silver Hill Hospital, and we are really delighted today to have you join us for our Grand Rounds, where we are privileged to welcome Dr. Holly Pragerson, and she's going to be presenting on the topic of grief and trauma, death and dying, and a way of thinking about it from a perspective she's calling empower. So I have the pleasure of introducing her in a moment. And for those of you who are used to seeing Dr. Katzman, I just want to say briefly that Dr. Katzman is traveling today, unable to join us. So we certainly miss him. And I've been asked to fill in and have the honor today of filling in, moderating today's Grand Rounds. First, a few housekeeping notes. Dr. Prigerson is our opening Grand Rounds for the month of June. And we, on June 22nd, have Dr. Lori Ello, who's going to be speaking to us about long-acting injectable antipsychotic medicines. And then finally, on the third Wednesday of June, our own Dr. Jeff Katzman, who's the Director of Education at Silver Hill, will be presenting on June 29th regarding climate change and mental health. So these June Grand Rounds will finish the first half of the year before we take a break during the months of July and August. So going back to today's lecture, we would love to hear from you. I'm going to be moderating a Q&A discussion with Dr. Prigerson at the end of her lecture, which is an opportunity for you to put forward your questions or your comments to Dr. Prigerson. You can submit a question anytime using the Q&A box on your Zoom function. And you can either use your name, or if you prefer, you can submit your comment or question anonymously. If you would like to receive CME or CEU credits for today, please do remember to complete the evaluation survey that will pop up in your browser when the webinar ends today. And finally, disclosures. All the planners, the speakers, or individuals in control of the content for this educational activity today have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. So it is now my great pleasure and honor to introduce our guest speaker today, Dr. Holly Pragerson. So Dr. Holly Pragerson is the Irving, Sherwood, Wright Professor of Geriatrics at Weill Cornell Medicine and the co-director of the Cornell Center for Research on End-of-Life Care. She has served as a principal investigator on numerous NIH-funded investigations, including studies that justified the inclusion of prolonged grief disorder in ICD-11 and the DSM-5 TR, and which have examined psychosocial influences on and the outcomes of end-of-life care. She conducts studies of racial and ethnic disparities in end-of-life care and studies of religiousness and spirituality, and has examined some online tools to detect risk of suicidal ideation in caregivers of patients with end-stage disease or in bereavement. She did receive the Harvard Medical School's Clifford Barger Excellence in Mentoring Award, the 2012 NHPCO's Distinguished Researcher Award, the NCI R35 Outstanding Investigator Award, and the 2018 AAHPM Award for Excellence in Scientific Researcher. So clearly, Dr. Prigerson's research, and she and I were just discussing it, is incredibly impressive, and I'm really looking forward to hearing her comments today. And so I'm now going to pass the baton over to Dr. Prigerson. Dr. Prigerson, over to you.
Thank you, Dr. Grote. It's a pleasure to be here. And when I say here, I mean it. I'm in Connecticut as well. So even virtually and geographically, I'm pretty close. So I'm happy to talk today about grief and trauma, death and dying in our Empower intervention. If there's time, I'll also welcome a discussion about some of the issues that have been raised about prolonged grief disorder's inclusion in the DSM-5 TR specifically, because I feel like this is an opportunity to correct cognitive distortions, if you will. So first, I'd like to disclose that I have nothing to disclose, no financial interest in the research. And the talk is really going to focus on, first of all, psychological responses to serious illness, dying, and death. And Dr. Grote and I had just mentioned that this is a very generalizable topic, that it's not specific. We've been focusing on advanced cancer, but it really can generalize to living with a whole host of chronic and acute and terminal illnesses, and what the psychological responses to those kinds of losses and adjustments are. I'll then be discussing how these psychological responses evolve over time, typically on average in most people and their loved ones. I'll be discussing briefly some predictors and outcomes of those psychological responses, and I'll end with a discussion, an introduction to our recently funded NIH multi-site study of Empower that we've been adapting in the context of Ukraine, in the context of COVID and various countries, and now we're adapting it to the PICU as well as the MICU. So, what are the psychological responses to serious illness, dying, and death? The typical responses when a loved one or a person is confronting an existential crisis is fear, horror, and worry, feelings of yearning to be healthy again and for their former self, feeling enraged and angry and bitter about why you, feelings of disbelief, feeling shocked and stunned, feeling sad, guilty about things that you did or didn't do that you may imagine caused the disease or illness or its impact on loved ones, feelings of helplessness and hopelessness. So, quantitatively, we wanted to assess in the ICU specifically how common are symptoms of what, peritraumatic dissociative experiences using the PDEQ. We wanted to know what % of a sample of ICU, critically ill patients, would meet moderate to extreme levels of these particular symptoms. And what we found was shockingly disturbing, sadly. One is 93% were extremely tense and wound up. 60% had sudden feelings of panic and blanking out or blacking out. 80% were extremely confused, where they had difficulty understanding what was going on. 85% felt extremely helpless to change anything. And 100% reported high levels of being frustrated, angry, and sad and grief-stricken. Now, these symptoms in the ICU predicted what's a very hot topic in intensivist critical care literature, which is something called PICS, post-ICU syndrome, where they look at what are the predictors or prognostic factors influencing who's going to have PTSD 1 month, 3 months, and beyond after discharge, assuming the patient discharges from the hospital. But we also found significant levels of psychiatric and psychological comorbidity in their family members. So we assessed the same exact symptoms on their family members in the of those same patients in the ICU. And we found really high levels of significant distress. Almost 60% reported high levels of sadness and grief. 34% reported feeling helpless, and about a third felt extremely frustrated and angry. In terms of the dissociative symptoms, 20% reported that things seemed unreal, and 17% reported that things appeared to be going in slow motion. We've also found that risk factors for those psychological reactions include being a caregiver of patients who are younger, particularly parents of kids in the PICU. But this was not this result that I'm presenting was not among children. This was just younger compared to older adults. Longer ICU stays, worse, greater symptom burden, and interestingly, patients who could not communicate, these were adults again, who could not communicate what their wishes were that the patients, caregivers of patients who could not communicate had higher levels of caregivers with dissociative symptoms. So how likely do terminally ill patients, their family caregivers, and bereaved survivors, bereaved caregivers, meet actual diagnostic criteria for syndromal levels of these particular symptoms and reactions? Now, first, I just want to acknowledge some of the formative work that went behind the diagnostic distinctions. And back in '95, we published a report that demonstrated what we call in principal components or factor analysis, simple structure, where the factors that describe depression, like sad mood and anxiety, fears and worries, were distinct and loaded on different factors than those that described a grief factor. So at that point, it was still an open question whether symptoms like identifying with the deceased or drawn to reminders or feeling their presence, whether those kinds of symptoms represented pathology. But the first question was, are they distinct from symptoms of depression and anxiety? And this analysis demonstrated these are three distinct mental health syndromes. So back to the question at hand, we conducted a study that was actually at Yale to determine what were the rates of psychiatric illness or mental disorder in a sample of advanced cancer patients and their most significant other primary caregiver. And what we found was that major depressive disorder wasn't that common. It was the most prevalent of the assessed disorders, mood and anxiety disorders, but it was 7%. Generalized anxiety was only meeting criteria, was only 3%. 5% met criteria for panic, which is much higher than the national average, but still. And only 2% met criteria for PTSD. About 12% met criteria as advanced cancer patients for having any of these, the above disorders. So we wanted to look at what we called mutuality and specificity of the relationship between if a patient meets criteria for one of these disorders, does the caregiver, and vice versa. And what we found was that depression was not contagious. We want to use that word cautiously because this was a cross-sectional, not longitudinal study, so we can't determine one caused the other. But at least the rates of major depression were almost identical. They were identical in that sample. Generalized anxiety symptoms were somewhat higher in the caregiver than in patients. Panic was higher, 7.5% compared to 5%, and PTSD was 3 times higher at 6% compared to 2%. So it seems like the caregivers, the family caregivers, are more anxious about what's happening with the patient than even the patient is themselves. Then we wanted to compare those family caregivers before and after the patient had died. And what we found is that the rates of PTSD dropped from about 6% to 4%, GAD halved from 4 to 2%. Panic dropped 8 to 4%. Depression stayed exactly the same. It seems to be 7% in the sample. And after the death, what we found was the most prevalent was meeting criteria for prolonged grief disorder, which this was assessed at a 6-month assessment, which is not the 12 months required in the DSM-5 text revision. And this is relatively high. We have prevalence rates closer to 3% in community-based samples. So what is prolonged grief disorder? Why is it a disorder? And what it is chronic, intense, distressing reactions or responses to the death of a significant other. That's these symptoms, as we showed in that factor analysis, that's why I presented it, they're distinct from symptoms of bereavement-related depression and anxiety. And they also don't respond to treatments like tricyclic antidepressants and interpersonal therapy that were shown to be effective for treating bereavement-related depression and anxiety. So it's a distinct cluster of symptoms about an attachment disturbance, yearning and longing and pining for this person who's no longer alive. Unlike normal grief, people with PGD are stuck in grief. They describe it as almost a Groundhog Day feeling, where every day they wake up and it's like it happened yesterday. Like they're hoping they're going to wake up and it will all be a bad dream. And what they find is no, they feel stuck in the state of chronic, intense yearning for something that they can't regain, which is their connection with a living loved one, with that particular, very specific to that person, that living loved one. The response is emotional numbness. They feel dead inside, detached. They no longer know who they are, where they fit in the world. And they often protest the reality that this really happened. Imagine seeing the person in crowds, etc. Prevalence rate, as I said, is about 4% in community-based samples. So the DSM had, based on years and years of evidence, including in 2010, when the DSM-5 was reviewing the evidence was ample then. It's only grown to demonstrate, A, these symptoms are distinctive from those of other symptoms in the DSM. They are chronic and disabling and upsetting in their own right. They're significantly associated with suicidal ideation. In fact, we've published data showing that symptoms of prolonged grief disorder are the strongest mental health outcomes of bereavement associated with suicidal thoughts and behaviors. So it's finally recognized, and I welcome addressing some concerns that the public and the press have promulgated about what it is and isn't at the end of my talk. So to review the criteria, the death has to have happened at least 12 months ago. We're not saying that the DSM doesn't say that all grief after 12 months is pathological. It has to be extremely intense levels of yearning and pining and feeling life is not worth living anymore without this person after at least 12 months have elapsed. So there's this yearning, this preoccupation with thoughts of the deceased, and at least 3 of the following 8 symptoms. Identity disruption, that you no longer really know where you fit in and who you are. Disbelief that it didn't really happen. It's just a bad dream. And avoidance of things not that remind you of the event, as in PTSD. It's not an avoidance of threatening, frightening violence, for example, or as if avoiding where a person was raped, or like, it's not that. It's avoiding reminders that this person is truly gone and not coming back. It's more, as you'll see in Empower, more experiential avoidance of accepting what has happened. And there's extreme emotional pain or pangs of grief and anger about not maintaining that connection to this person who's so central to in your life. A difficulty reintegrating into a life without this person, feeling emotionally numb or dead inside without this connection to this loved one. Meaninglessness and a sense of intense loneliness and isolation in the world. And these symptoms are required for a diagnosis to be not only distressing, but also impairing, so that they're associated with an inability to work, to watch your grandkids, to function and as a family member in any important domain in your life, that there's significant functional impairment in your ability to perform your usual activities because these symptoms are just derailing you so intensely. So another controversial, and I sort of laugh about the fact that this is controversial, is examining the stage theory of grief, because we went into studies of the stage theory of grief basically thinking this would be the least controversial study that we've ever done. We've removed those who were stuck, those who met criteria for prolonged intense grief. This was only intended to be a study of how mean levels of the DABDA acronym for the stage theory of grief, the disbelief, anger, bargaining, depression, and what she called acceptance, that we just wanted to know patterns over time and whether there were systematic evolutions in intensity of these 5 grief indicators that would align with Kubler-Ross's stage theory of grief. Now that has sparked intense outrage, a lot from bereavement, quote unquote, experts and counselors. So there was a lot of mothers of drunk drivers also have found this notion really angering and enraging, because they feel like someone is telling them what they should or shouldn't do. These data were not intended to prescribe or tell people what's normal. Well, they weren't intended to demonstrate normative patterns of response over time. They weren't telling people what they should or shouldn't do, nor was this a study of mothers of drunk drivers. This was a study of later life bereaved people, mostly from widows and widowers from cancer deaths. Anyway, despite all the controversy, which I hopefully will dispel by the end of this talk, there is undeniable, it's hard to refute that the initial response psychologically that a person has when you hear either that you have a life-threatening illness or that a loved one has died is this deer in the headlights sense of shock and disbelief. This news is so bad. I can't be hearing. I can't deal with it. I need to remove myself from this awful. This is just too bad, and I'm shocked and just I can't accept this right now. So it's really shock and disbelief. The other truism is that over time, people come to adjust and accept, for better or worse, almost anything. People are highly resilient and adaptive, and we take issue with the word acceptance because that seems like a pretty high bar to say that people are like okay with, they're resigned that this is their lot and the lot of everyone, and this is what happens. It's more of a resignation in the context of dying, which was what Kubler-Ross focused on, was and that's why we have the frog in boiling water. That's the circumstance of the patient thinking about and responding emotionally to their impending death. A very smart research assistant challenged me to say, well, are you saying the bereaved person's going to be like the frog in boiling water and die? And I'm like, no. So this is for the idea of reintegration and adjustment applies, but for bereaved people, it's reintegration by forming new and other attachments as a living person, not as a dead frog. So in the Yale bereavement study, we tested the stage theory. So we wanted to know the prototypical, we took the case of prototypical bereavement, late life widowhood, following death from natural causes. And we found that most bereaved people accept or say that they accept death, even initially. Acceptance increases over time from loss. And on a scale where 1 was less than once a month and 5 was multiple times a day, this was the plot of the responses over time. So what we found is that acceptance, self-reported acceptance of the death was very high and did increase over time. We were surprised to find that yearning, not depression, was the predominant negative grief symptom, and it remained the predominant response to bereavement over time, but it tended to decline at around 4 or 5 months post-loss. Disbelief was most prominent initially. Depression came after the yearning. Anger was somewhere in the middle. So we initially, Bonnie Zhang produced these plots over time in our Yale Bereavement Study data. And my husband, Paul Maciejewski, who's a statistician, said, I see something different. Now, if in these data, if we were to rescale each of these 5 indicators to say, when do they peak? When is each one, quote unquote, maximally expressed? When is disbelief the highest? When is yearning the highest? When is anger and depression and acceptance the highest? When did each of these peak? And what we found was that it was exactly the sequence that Kubler-Ross had proposed for dying patients, and Bowlby and Parks had proposed for in bereavement. And the likelihood that by chance that the disbelief would come first and yearning would come second and anger would peak third and so on was 0.008. So this wasn't just a fluke. It was very unlikely that our data were just got incredibly 0.008 percent times lucky at supporting the Kubler-Ross theory. So we're like, there is some evidence, at least at the very minimum, that it's first disbelief, that people reintegrate over time, and yearning and anger and depression. I think that they go back and forth over time. Even disbelief, sometimes you still can't believe it, even in normal, not pathological, prolonged grief disorder reactions. Grief is a co-traveler, as we like to say, throughout a person's life. It doesn't mean that it's ever all going to go away, and people have pangs of grief at anniversary reactions or triggers when there's a reminder. We're not saying that will ever go away after the first month, but we're in these longitudinal studies, when we wanted to know when was disbelief the most felt, it was initially, and when was acceptance the most felt, and that was ultimately at the end of the study. By contrast, we wanted to know what if this was also old, and I apologize for how crude it looks, but it's using data where we diagnose people with prolonged grief disorder using a 6-month diagnosis. And what we wanted to do here was plot their mean grief scores on those symptoms. At the time, we called them the inventory of complicated grief, their mean grief scores from the beginning to the end of the study, for those who didn't meet criteria at 6 months. And what we were worried about was that the initial symptoms, the red, would plop down into the blue and turn purple, and that they'd be quote unquote false positives. And we'd be identifying people who, if you'd just given them enough time, their grief would resolve and they would be unstuck, and it would fall into the level of the blue. So the blue was actually the people in the Yale Bereavement, the stage theory analysis. These red people had been removed. And as you can see, the point of this is to show these without intervention. This is a community-based sample in Connecticut. Those who met criteria at 6 months were the same people who were going to meet criteria ultimately, and time alone was not going to heal their wound. So now let's talk about what are the factors that would make psychological responses to impending or recent death worse or better. And we did an analysis, as I said, testing contagion, but it was cross-sectional. Basically, we wanted to know if a patient meets criteria for a specific disorder, what's the likelihood that their family caregiver, their primary family caregiver, usually in this study, it was their wife or husband. Most often their wife, because men die before. Most of the patients were men and most of the caregivers were women in our study. And what we found interestingly was that depression was non-contagious. So, the Freudian notion of anger turns inward, or it's an internal process. It seemed like people who are depressed were not more likely to have a family member, and vice versa, patients who was depressed. So it was less spreadable in that way, or shared psychology. The opposite was true for PTSD and the anxiety disorders. So if a patient met criteria for PTSD, the caregiver was way more likely to meet criteria for PTSD. If the caregiver met criteria for PTSD, the patient was more likely to meet criteria for generalized anxiety disorder or panic. If the patient met criteria for generalized anxiety, the patient was much more likely to meet criteria for panic. So the anxiety disorders appeared to be more shared by dying patients, cancer patients, and their family members. And overall, there was a significant association. If one met criteria for disorder, then the other did too, but that was largely driven by the anxiety disorders. Now, this part of the talk, I'd like, if it's possible, to have it be interactive. And I like asking mental health professionals because they might have some experience with these situations and have some reason for the response. So I'm going to hope it flies. I'll read very briefly items from our SCARED scale. And I'd like to ask people to show their hands if they think which of these experiences do they believe is the most likely to make the family caregiver meet criteria for an anxiety disorder, very generalized anxiety. And so there's the patients being confused or delirious, a show of hands. I don't know if Dr. Grote can see them or Jen can see them, but experiencing extreme pain, unable to eat or choking, vomiting, dehydration, insomnia, collapsing, thinking the patient had just had enough, walking into the room and thinking the patient had actually died already, and the global sense of caregiver burden. So I'm curious, how many people thought confused or delirious was the main risk factor?
Dr. Prigerson, they can't raise hands because
they can't. Okay, so I will jump to the punchline because almost everyone gets it wrong. It's delirium. Delirium is really extremely upsetting, and that's one of the reasons why in our Empower intervention we select patients. Delirium is very common, especially like 90% of advanced cancer patients are delirious before they die in the hospital. And that's one of the most upsetting exposures or experiences that a family member can witness, which is somewhat counterintuitive because it doesn't seem like they're necessarily in pain or suffering, but seeing a delirious loved one who has advanced cancer is extremely upsetting and anxiety producing for their family member. Vomiting was, insomnia was, feeling that the patient had had enough, and caregiver burden were also bivariately very much related, but over and above these competing risks, delirium is a particularly aggravating and upsetting thing for a family member to witness in a dying patient. So what are the risks for mental disorders among bereaved people? A while ago, back when I was at Yale, we did a study looking at, was it marital harmony and discord? Was it feelings of parental neglect or control, which have been predisposed to people to psychopathology later in life? Was it emotional dependency on the deceased person? And what these analyses showed pretty clearly was it wasn't whether the marriage was quote unquote like good, harmonious, or there was a lot of conflict. That wasn't related to whether the person did or did not meet criteria for prolonged grief disorder. In fact, Freud had hypothesized ambivalent relationships would predispose to pathological mourning. And that's not what this analysis revealed. We did find, and it wasn't parental neglect either, it was parental control specifically, which was significantly related to having a partner or a spouse on whom the caregiver was very emotionally dependent. Also, parental control had a direct, significant effect on the risk for prolonged grief disorder in bereavement. So people, mourners who described their parents, at least one of their parents, as very controlling of them, were at significantly greater risk of prolonged grief disorder. But a lot of it was mediated by selection of a partner on whom you were very emotionally dependent. And that alone is the single biggest risk factor for prolonged grief disorder. So this is an important distinction, especially from PTSD, where people say, oh, it's how the person died and the trauma of what happened at the end. That's all, that complicates adjustment for sure. But what these results suggest is prolonged grief disorder is about a relationship. It's about a particular attachment to a person, that without that person, it's very specific to that person, that you feel like you really don't know who you are anymore, where you fit in, how you're going to get by, because you just needed this person so much to be your best you. So that's the main risk factor for prolonged grief disorder. And we did an analysis of prolonged grief disorder as the outcome versus depression. And what we found is it is these relationship features, none of which were related to meeting criteria for depression in the context of bereavement, and all of which were very significant correlates of prolonged grief disorder. So it's that this person made you feel secure, that you depended on this person, that you would confide in this person, that this person would provide you with very active emotional support. And 6.69 was the correlation for all those above: the security increasing confidant who provided emotional support. That's the person who's at much, much, much greater risk for PGD. And it's less about the overall quality of the marriage. We also wanted to know how does where the patient died affect bereavement mental health? And what we found was that, and now that I do so many studies in the ICU, I'm aware of how psychologically traumatizing the situation of someone dying in intensive care is. And this was all exacerbated greatly by COVID, including personally. My mom died of COVID in the ICU, and I get it. I get why it's traumatic, and it makes sense to that, for example, that patients who died in the ICU, their family members at 6 months post-loss were significantly 5 times more likely to meet criteria for PTSD at 6 months post-loss. This is also controlling for pre-loss PTSD about 4 months before the patient died. Without controlling for it, the risk was 7-fold higher. So there is a huge risk for exposure and experience of being psychologically traumatized, witnessing your loved one gasping for air, making decisions that you may or may not regret as they're literally suffocating, extremely in pain, and you've got to make calls about what to do about it. And so that's a very potentially traumatizing situation, and that's one of the things that Empower is intending to target and reduce those rates. Dying in a hospital was linked to increased risk of prolonged grief disorder at 6 months. And that's hospital and even hospice. We've shown that there's some selection bias there, because who goes to the hospital and when they go, or who goes to hospice, including the Connecticut hospice, which is where we initially found this and developed the SCARED scale, that hospice is people who have earlier enrollment in hospice tend to have less grief maladjustment, that they've accepted that this person's dying, and it's confounded with selection into that type of treatment, and the reverse for being hospitalized. So I hope that these data have set the stage, provided the background for why we're addressing the problems of psychological issues of family surrogates in the intensive care unit, and now generalizing to other circumstances. For example, war in Ukraine, it's actually very adaptive. It applies to that situation pretty neatly. Anyway, these are the conclusions, is that critical illness can put both patients and family members at risk for psychological distress. The burden may be especially great for surrogate decision makers of incapacitated, delirious, for example, dying patients in the ICU. And COVID's made this bad situation much worse. And there's a need to help these families, helping them cope with an extremely psychologically distressing situation. So we've adapted Empower, enhancing and immobilizing the potential for wellness and emotional resilience in family surrogates of patients who can't communicate and are dying in the ICU, as determined by the intensive care team. It's 6 really brief, about 15-minute modules, administered very flexibly, because a lot of times the family doesn't want to be away from the bedside, so they can go back and we can resume later to accommodate medical crises, interruptions, and be flexible that way. It can be delivered in a single session if there aren't interruptions, or these 6 separate modules. And we have 2 booster sessions each 2 months after the end of the intervention. In total, it's about 180 minutes of an intervention. It basically incorporates things that most people here in this audience probably are familiar with: cognitive behavioral and acceptance-based techniques, and some grief meaning-centered therapy techniques. Our conceptual model is that we screen the family member for potential risk of prolonged grief disorder or PTSD following the ICU death. And we've shown in the past that one of the best predictors of post-loss grief is pre-loss grief, and one of the best predictors of PTSD is peritraumatic stress and or anxiety in the ICU. So we screen them. The patient is dying, isn't communicating, their family members feeling levels of extreme pre-loss grief, which are the same symptoms minus the time from death, and severe symptoms of anxiety. We acknowledge it's a potentially traumatic situation. We begin with mindfulness grounding exercises to calm the family member. We provide a brief psychoeducational introduction to what is peritraumatic stress, what is anticipatory grief, what is experiential avoidance. We review some cognitive behavioral and acceptance-based strategies to build distress tolerance. But the element of empower that most family members don't want to do and are most reluctant to and didn't like the most, we are told by them was the most helpful ingredient in the mix. And that is invoking the patient's values and perspective to aid the surrogate decision maker using role play. So we say, we don't force a situation to sign a DNR order. They're being hounded to do it. We don't tell them they should. We just have them imagine the voice of what the patient would likely tell them their preferences are. And we help them think through how to make a decision that they can live with, that they think is in the patient's best interests. And they've said that that's probably the most helpful element of Empower. And so, I won't belabor what all the modules are. It's pretty textbook CBT modules for the most part. And we found in a preliminary R21, very strong effect sizes. So it's a large effect on pre and post loss grief that was maintained over 3 months. There was an effect so in the adults, the effect on the state anxiety was not key. However, in the parents in the PICU, that was the most impactful element. It helped them the most, and that's what they were having the most trouble with. It had an effect on depression, depressive symptoms, a small effect on peritraumatic distress long-term, but a significant effect, very large effect on PTSD long-term. We think it's moderated by experiential avoidance, and it significantly reduced the family member's regret after the patient died about the decisions that they made. So the model does target experiential avoidance as the mediator. We currently have funding. We were just funded by NIH to do a multi-site study of Empower at New York Presby Hospital, at Weill Cornell, at Memorial Sloan Kettering, at Penn. And what we're trying to do in that study is basically do a confirmatory analysis that tests for mediation and moderation to see whether the reasons why it's so helpful is because of distress tolerance and targeting experiential avoidance. And I'll end with a quote from, it was our first Empoweree, but she's sort of characterized it better than anyone. And she said, "It wasn't something I was really looking forward to or looking to when I didn't think it was going to be helpful for me at the time, because there's so much on my mind. But after being placed in the room and having actually talk about it when I barely had time to eat or let alone think about, oh, I should get to therapy, it wasn't something I was actually thinking of. But at the end of the day, it really, I don't want to feel over dramatic and saying like it saved my sanity, but it really did, really did give me a support that I didn't really think I needed until I actually did it. And then I realized what a weight off my shoulders it felt like to be able to talk about it. So, I sat down and I asked questions about things right in the hospital, kind of, if I had to, I just go out and take care of something with my mother. So it was very helpful. I can't express how helpful it was. So, we're very proud of this intervention because we think it's not provided in a situation where it's so needed, and it's proven extremely helpful. So in conclusion, dying patients and their personal family caregivers experience significant symptoms of anxiety, depression, grief, and peritraumatic stress. These symptoms mostly resolve over time as people come to accept or become resigned to a loss, but can predict enduring distress and disability, as in the case of PTSD and prolonged grief disorder. ICU and hospital stays and deaths result in more psychiatric morbidity for patients and family caregivers, empowers a psychosocial intervention to reduce psych distress, improve end-of-life decision-making and care, and result in better caregiver adjustment. So with that, I want to thank you for your time, and I welcome any questions that you might have about this work or work on prolonged grief disorder. Thank you.
Thank you, Dr. Prigerson, for your very thoughtful presentation. And, it certainly has stimulated a lot of thoughts for me, and I imagine for those who are tuned in today. So I want to thank everyone here for joining us. And as a reminder, for those who are wishing to receive either CME or CEC or CEU credits, please complete the evaluation survey that'll automatically pop up in the browser as the webinar ends. So I want to move now to talk about the questions and things that people are putting forward. And I want to help get us started on this by putting to that, it's quite remarkable as you're talking about the empower approach, that you're setting aside time, you're marking time to say, I want to set aside time to talk together about the impact of what you're going through, and to open up a space for us to be able to face this together so you can begin putting this into words, putting your mind around it. And it's quite remarkable, this preparation for this inevitable decline and death. And it's obviously quite difficult to do. And I'm curious to know how you prepare the clinicians who are in this process of sitting with people, right? They're in the middle of ICU, or they're in hospice, or someplace where the death is there. It's a reality that can't be avoided. And the different kinds of reactions staff might have to providing this kind of intervention, and how you prepare them for that, what kind of support is provided for staff as they administer this powerful intervention.
Yeah, that is actually not a question. I've been doing this for a very long time, and surprisingly, when I give this talk, that's not the question that I've gotten. Mm-hmm. In developing Empower, I got that question from clinicians all the time, and they're like, empower me, I feel so unempowered. And in the PICU, we're told parents feel especially empowered by the staff, because they can't do their role as parents because it's sort of been taken over by the critical care staff. But I actually wrote with Wendy Lichtenthal at Memorial Sloan Kettering, and I and Kaylee Roberts at Yeshiva. We wrote something for Annals of Internal Medicine about that was mostly just in the height of COVID, how to make a condolence call and tell people that their loved one was dying, because that's extremely upsetting for clinicians to be. And even with my own mother, he was a young attending, and I was like, I almost felt sorry for him when he was calling to tell me that my mother had died. I'm like, how many, he sounded so green. I'm like, is this like one of the first times, he was so young, is this one of the first times you've had to say that? And he's like, sadly, with COVID, this is like the 100th time the last month. So I think that there's been a lack of attention to how much it relates to burnout, how much clinicians were just overwhelmed by trauma and grief, especially during the pandemic, when they also denied access to their family members and quarantined. and not allowed to have the family members helping and talking with their loved ones. Everything was on a tablet, like it is like right now. And I think I definitely think it would be a welcome intervention to come up with a way to empower clinicians so that they don't, I do take issue when some people have said, for example, with oncologists, that physicians feel grief over the loss of their patients, because as I've said in this talk, grief that we're talking about is about a really crucially significant person in someone's life. And I know doctors, physicians think that they are very, very important, and they are very important, but they are not a significant other in the way that a parent or a spouse or a child is. And that relationship doesn't result in yearning for them as they used to be and missing their time together and defining. So I think grief is not the relevant target of an empowering clinician's intervention. I think it would be more about the trauma and feelings of helplessness and hopelessness and burnout, and that there's very little you can do to prevent this, and empowering them to feel like they have some control, because there must be just this a perfect storm of social isolation, lack of control, overwork, bad shit happening. Let's just be blunt about it. A lot of people dying in ways that are suboptimal at best, euphemistically. So I think your point is extremely well taken, and I think that clinicians, especially during the pandemic, would have benefited from having an empower type way to deal with all the emotional trauma that resulted from being on the front lines of a global pandemic and being like in a sense, they were not the police officers at Uvalde who had a choice that, whether people like it or not, they decided not to go in. Physicians aren't given that choice. They're told, suit up, wear some hazmat suit, and go in there at risk to self and family members. And so when there's a good reason there are all those hearts around the country for the sacrifice of health professionals during the pandemic. So I think I've over responded to your question, but it's a good one. So thank you.
Well, it brings up a lot, right, around how do we care, how do we in leadership roles care for those staff on the front lines who are experiencing vicarious traumatization or experiencing, carrying this kind of, chosen mission, but the mission has its cost, emotional cost, and emotional toll. So I really appreciate your thought on that. And I do want to open up to some of our other participants today. We have Dr. Richard Francis, who at one point had been the medical director here at Silver Hill. Hello, Dr. Francis. He asked today, what effects on grief and the family member of patients who sought out and died from euthanasia? So he's curious to know if you have any ideas.
Actually, I've worked tangentially with Linda Ganzini in Oregon. You may be familiar with her work. So Linda had done some studies, and I worked with her because I was the grief assessor. I was helping her with the research design on studies in Oregon, and I think there were some studies in the Netherlands also about. Oops, I'm sorry. I can't. Can you see me? Can you hear me?
Yeah, we can hear you. Yep.
Oh, because you guys went away. So that both patients, family members of patients who had opted for euthanasia in Oregon had their surviving family members had significantly lower rates of prolonged grief disorder and other forms of psychiatric morbidity post-loss. But that might be something akin to what we found with the hospice, where there's selection into, if you're opting for this, you've made peace with the
Yeah.
fact that
Yeah.
it's better to hasten a
Mhm.
miserable death than to prolong it. And the sooner the better, and you feel some sense of relief in diminishing suffering. So we did find that with respect to a physician aid in dying, I think is probably the term current. The terminology seems to shift a bit, and I think that's the latest. But it's associated with lower rates of psychological disturbance and improved bereavement adjustment. I think it also gets to the sense of control, that I think one of the fears of people who are confronting Lou Gehrig's disease or some illness that creates panic and concern about suffering at the end of life, to have a sense of control that when it gets bad enough, you will have the means to put an end to your suffering. And that sense of control is a great comfort, both to the patient and to their loved ones.
Yeah. Well, that makes sense. I mean, clearly this theme of preparation makes a difference, and I see how that applies here. Thank you. Going on to Dr. John Tamron, who's a friend of Silver Hill and a psychiatrist. And he asks, what have you learned from how various other cultures deal with death that has proved relevant to helping the patients you deal with? And he's particularly thinking about the relevance of cultural anthropology as you think about your work.
Well, that's a very timely and important question. And it was important to the DSM as well. So I have a few different reactions to it. The first reaction is that I consider grief to be a universal mammalian response to loss, and that how it manifests. The people and other mammals have close attachments to their family members and other loved ones, and how that manifests itself, what are cultural prescriptions for appropriate behavior. That part varies widely, but the basic feeling of yearning or pining or missing something that is gone that you love dearly, that's a universal sentiment. Oh, I apologize. Regarding the universal and cultural prescriptions for what's appropriate. So, for example, I lived in Spain for a junior year in college a zillion years ago, and they had a culture of viudas, and that they were expected to wear black for the rest of their life, and there was a whole culture of viudas, and there are cultural prescriptions for when it's appropriate to go out in public, what to wear. Indian culture has different rules about what wives of deceased husbands should or shouldn't do. And I mean, I won't go into all the different cultural variations. People have taken our prolonged grief disorder scale and transcreated it and culturally adapted it. Certain cultures, it's been extremely challenging. In Nepal, it was hard too. Some of the language is different. Some cultures don't even have a word for grief. And certain symptoms like feelings of emotional numbness or detachment didn't translate in certain cultures. People understood yearning, they understood bitterness about the loss, lack of meaning in life. Those reactions are largely universal, but particular symptoms needed to be reworked. And I think that culture does play a role, and one's social environment plays a huge role in what people do, and what they do affects how they feel. So we have what we call our micro-sociological theory of adaptation to loss. And our shtick is that so much is focused on the individual personal psychology of loss, including our own work. But what has been missing from the conversation is that bereavement, by definition, is a social event. It's because some other is gone. And the psychosocial emphasis on social deprivations and voids created by that loss need to be addressed. And how each culture addresses those psychosocial voids or deprivations will be different. But the way that you figure out how to address those deprivations, we posit is the way to understand and address and enhance adjustment post-loss. And that will be culturally specific.
Yeah, no, that's very helpful. And I think one of the things you're pointing out is as this kind of mammalian link that's worldwide, the sense of attachment. And we can talk a little bit more. I'm curious about your observations that those who manifest excessive dependency have real difficulty, moving into a more self-defined life. And we can certainly come back to that. But
yeah, what I like, Dr. Grote, is that I blather on and then you just summarize it really well. So thank you for yes, and it is about attachment, and it is about these relationships, and it doesn't have to. It could be for a pet. We don't want people being totally outraged that there's a disorder for people who are bereaved after their pet dies. But I think any pet owner would understand that you definitely can feel significant grief when your dog of 10 years has died. And it's not only specific to older white widows in Connecticut, which we've been faulted for. It's a universal phenomenon.
Yeah. Well, let's have some other questions here, and love that people are sharing their thoughts and questions. We have a comment here, a question from Ethel Schatz. Looks like you're a local social worker. Welcome, Ethel. She's asking, is there any difference if death is unexpected and is due to accident or, like, for example, a cardiac arrest? Does this immediacy of the death change the grieving process?
Yeah, so that's a great question, and one that I get a lot, and it's a little hard to answer. Just the quick answer is yes. The short answer is yes. In fact, this morning, there was a paper just published on our prolonged grief PG-13 scale in Korea, and the conclusion was that traumatic deaths were associated with higher rates of PGD than non-traumatic deaths in Korea. But we also did an analysis of whether COVID-related deaths were related to higher rates of prolonged grief disorder than non-COVID deaths. And one of the things we found is COVID deaths were related to higher rates of PGD than deaths from dementia, but not deaths from cancer or heart disease. And we think that there's the timing issue is key, that with dementia, that there's less preparation, as you correctly pointed out, that it denied that even in natural circumstances, the rapid demise that accompanied COVID deaths, that people would enter the ICU and die within 3 days, it denied mental and emotional preparation for what was likely to happen, and was associated. Those deaths are associated with higher rates, but not higher rates than other longer term illnesses like dementia. We found also, and it's been found, Martin Eisma in the Netherlands and several others have shown that unnatural, he calls unnatural deaths, homicide, suicide, disasters, as like every other day mass shootings, those are associated with higher rates of PGD and PTSD than deaths from natural causes over and above the timing-ish thing. So the short answer is yes, but there are qualifications. The other qualification is, like, even when we first started studying what we were calling complicated grief at the time, one of the first treatment examples was someone describing her husband being life flighted between like Tennessee and Buffalo and Pittsburgh, and the description of the death revealed that this person had been dying for months. But when asked whether it was sudden and unexpected, almost 100% of the people, when we ask them, say that it is, regardless of if, when you dig deeper, there were signs and symptoms all along. But that's part of that whole experiential avoidance piece, where even in the case of dementia, someone will say they just died. And like, well, it's been 20 years, but it feels to someone like it just happened.
Yeah.
So it shouldn't be the subjective sense of suddenness, rather more traumatic versus untraumatic do seem to complicate the bereavement adjustment.
Yeah, okay. That's a great question. Thank you, Ethel, and thank you, Dr. Prigerson. So we have Dr. Dana Luck, local psychologist, she's saying, please tell us about ways to utilize some of this knowledge in situations involving large-scale atrocities. And so you've been referring to that.
I know. Well, thank you for that really important, sadly relevant question. I do want to say that we are working with the chair of psychology at Ukraine Catholic University in Lviv, because he's adapting it for the context of war. And we thought it would require, we trained social workers and his psych grad students, master's level. And we thought it would require a whole bunch of adaptations that wouldn't exactly make sense with the manual and it fits that situation really well. So, we think that kind of very brief, very focused, trying to keep people not dissociating, those techniques appear to be very generalizable to different situations. Now, we haven't tried it, obviously, in the wake of Uvalde or and any of the future horrific disasters that are yet to come, including Sandy Hook. So I'm sad to say that there probably will be, and to Dana's point, there probably should be attempts to see how helpful Empower could be. I think one thing that people are concerned about, especially after 9/11, is critical incident debriefing and re-traumatizing people, or doing more harm than good by not doing the right thing when someone's in such a vulnerable state. So I think we'd want to proceed with caution on how best to intervene in the context of a mass shooting. But that, to her point, I think that I'm not a psychologist, and I've been convinced by the data from these studies that targeting experiential avoidance and whatever's in the secret sauce of Empower is working. And so I'm a skeptic even of my own interventions, but when the data are this compelling, it makes me want to work with others who are psychologists to apply it and adapt it. So I welcome any future collaborations to apply it to these new situations.
Yeah. Well, I'll say one thing briefly, that as you reference within med-surg settings, you have people who are dealing with various kinds of illnesses that can result in death. And even within psychiatry, right, we have situations where we lose people, and we lose people at times to suicide, which is often it's feared, yet often unexpected, and can come as a real surprise. And so, I think then that people within mental health are faced with the challenge of how do we mourn the loss of someone that we have cared for and come to terms with this reality. Because I think that, thinking about some of the things you mentioned regarding different aspects of grief, there is this element of, you said acceptance is maybe too high of a bar, and I would tend to agree with you that perhaps it's a recognition or a resignation, some kind of recognition that we can do our very, very best, and yet still sometimes lose people, which is, a painful kind of reality.
Yeah, and also when I said that, physicians don't typically feel grief, I'm not saying, for example, a psychologist or a psychiatrist who treated someone with opioid addiction who overdoses wouldn't feel grief, because that's not the same. That I could definitely, that it does seem relevant because you've cared for this person and you feel responsible for them, and it would affect your sense of self and who you are and your ability to do your job and to give back and all those things. So I do think some of the grief work in that context is very relevant to clinicians who are dealing, especially with, substance abuse and suicidal people, bipolar people who might be making attempts more often than others. And I would think that there are exaggerated or at least intense feelings of guilt and responsibility for right or wrong. It's an occupational liability that's just like the police officers, their occupational liability was just going to a school with an assault weapon. A psychologist or psychiatrist who's dealing with a suicidal person is dealing with someone. I mean, they could have a firearm as well. So anyway, I feel your pain. I don't know. And it does sound grief related. And I do think that there are applications that seem worth at least exploring.
Yeah, I think there is this, I want to go on to some other comments here, but I think there is this piece around, you've been talking about trauma, right? And you've been talking about grief and loss. And I think, we can experience a sense of being traumatized by the sudden loss of a patient through suicide, and then be left, anxious and, questioning ourselves and even getting into a stuck place.
Well, even as a very different example in the realm of trauma, a long time ago at the ISTSS, I met with Chris Bruin, who does a lot of PTSD work in London. And he was explaining to me how CBT would work with a police officer there that he was treating, who couldn't go to work because he saw someone's brain all against a cement wall. And he kept having flashbacks and he couldn't go back to work as a body. And he was just having nightmares, and he felt like he couldn't do he wanted to be a police officer. He couldn't do it anymore. So he came up with all these kind of clever and more importantly, effective approaches to cognitively restructure that traumatic image. And he did return to work, but it was addressing the trauma of his job, like job associated trauma. And how do you both do the work that you want to do and are trained to do when it's interfering, when feelings of trauma are interfering with your ability to function. So it's very, I don't have the answers, but they're very good questions.
No, these are complicated issues. So, thinking about, we've been talking about some of the more, particularly extraordinarily adverse experiences around death, and want to talk about some other forms and very thoughtful questions here from Cheryl Bundy, who is our director of spiritual care. And what she's wondering about is there can be what she describes as this kind of disenfranchised grief. In other words, grief over obscure losses that others may not always acknowledge as traditional grief. For example, the loss of a job, the loss, we've already mentioned, the loss of a pet, the loss of some experience and going through a graduation, a wedding, what you're leaving behind.
The family farm.
Yeah, the family farm, the life or career that you thought you would be living, the loss of opportunities, the loss of hopes and dreams, right? And, this grief is very real right now. And it's, complicated by the fact that it doesn't fall into these kind of grief buckets, like we're talking about today with death. Involving
In a way, it might. It's a very interesting question, especially because, there have been some high school students who've done summer internships. And what I would hear from them is the loss of their childhood, like the loss of the pandemic really is going to precipitate a generation that's going to feel that they didn't have the opportunity to have the childhood that their parents did, or that the world has had since the beginning of time. And I feel like maybe that's an exaggeration, not beginning of time, but I feel like there are these other losses, and we define grief as the loss of anything that you find self-defining, dear, and cherished. That you the word bereavement means robbed. And grief is that emotional response to feeling that you've been, that's what we talk about, psychosocial deprivations. Things, you've been denied something that you psychosocially need. And it could be high school graduation, or, attending the prom, or whatever those things were that you envisioned were, you were owed. You were entitled to have a childhood, and you might, will your ability to resolve grief over not having that trickle down and impact the rest of people's lives? And I don't think it's an exaggeration to say that it will. And coming up, I think if there's a silver lining to global pandemics and mass shootings and all these horrific events that you just hear in the news every day, it does make a person appreciate that our time is short. And my mother-in-law used to say it's later than you think, and that rather than grieve over what you didn't have, you have a choice about making the most of the time that you do have, and focusing more on ways of making the most of your time, rather than wallowing in feelings of being deprived and resentments about that. Which, I mean, I think it's helpful to express that and not keep it bottled up. But after you have shared it, in thinking about what are you going to do now, acknowledging what happened was unfortunate and bad, and they were denied things that they felt that they needed, but also thinking about ways of addressing those needs in the future going forward. It seems like a useful exercise. And I'm really going out on a limb because I'm a sociologist, so I should not be offering suggestions for therapy.
Oh, I think you're, though, speaking to kind of a large social level, right? How do we, as humans, as social communities, deal with all kinds of losses? And one of the things that comes through today in your message, I think, as a sociologist, is that our attachments to other people can be our greatest source of comfort and soothing and support.
There you go again. You just summarized better.
Potentially our greatest source of pain, right? And heartache and heartbreak. So, well, I have a lot of practice.
Well said.
So we have a few other comments here.
Oh.
Yes, and one has to do with Joe Fletcher is wondering about whether the empower approach draws from what's called ACT, acceptance and commitment.
Oh, it definitely does.
Okay, that's what I thought. Yeah.
Yes. Okay. No, and that targeting distress tolerance and tolerance of uncertainty, and experiential avoidance. It definitely, and it also has some of the Viktor Frankl meaning-centered logotherapy from grief interventions.
Interesting. Very thoughtful. Okay. Well, some other comments here. One is, what is the role you think of faith or perhaps belief in God in diminishing a prolonged grief reaction?
Yeah, oh, that is.
And just another comment, someone named George had asked, does a belief in afterlife help with grief? So looking out.
So the questions about spirituality. So we actually have in the other part of my research portfolio, we have something we call our divine intervention. And I, in the interest of full disclosure, I'm Jewish and not observing and not religious, but I am an empiricist, and our data show that at the end of life and in bereavement, religious belief and support and existential suffering is real, and when it's addressed, outcomes are better. So we actually have under review a large multi-site study to enhance the early integration of healthcare chaplains, because we've shown that whatever's in the special sauce of healthcare chaplaincy, dealing with it, discussing existential issues for advanced cancer patients. So we want to make it upstream in the outpatient oncology setting, not just in the hospital as someone's dying, because we think there's a huge burden on advanced cancer patients that they don't feel comfortable talking to their oncologist about these existential concerns that they have, but they welcome talking to chaplains who provide, as you had said earlier, the emotional space and time and place to discuss some of these less black and white scientific medical issues that are hugely relevant to someone who's confronting death and either of themselves or of the loss of a loved one. So the value of being able to meet with a healthcare chaplain in terms of earlier referral to hospice, in terms of not seeking palliative chemotherapy that's going to have someone die with toxic chemo rather than comfortably, of addressing. We even show huge potential reductions in racial and ethnic disparities at the end of life, given concerns that medical establishment might not respect and see, using the W.B. Du Bois notion of lifting the veil. We think healthcare chaplains have the capacity to have Black patients in particular feel seen within a medical setting in ways that their oncologists might not. So we think that there's enormous, in fact, another talk that I gave 2 weeks ago is about our divine intervention on the untapped potential of healthcare chaplains in the context of death and dying. And I think everyone understands when you're talking about existential concerns, they definitely have a role, but how much they might reduce feelings of discrimination and prejudice in delivery of care, and having patients feel seen and heard, and addressing things that they don't feel comfortable talking to their family members about, or their oncologists about, or maybe even their psychiatrists about, that there is definitely untapped potential in leveraging what healthcare chaplains have to offer.
Yeah, no, that's incredibly powerful. And I think we're going to have to wrap up here. And I feel like we're going to enforce or put in place a certain kind of deprivation of the continued conversation, right? Because this is a rich conversation, and I really wish it was one that we could continue together. And I really just am so grateful, Dr. Prigerson, that you've taken the time today to share your insights with us, this incredibly powerful research you're doing, and help us all think together around how we all as humans face these kinds of issues and the complexity of them. You provided us some
It's been
ideas.
my pleasure. And if
Yeah.
there are any other questions that I can attempt to answer, please
Yeah.
feel free to email me.
Okay,
Thank-
perfect.
thank you.
I want to thank everyone for joining us today. As a reminder, please fill out your surveys for the credits, and this now will conclude our grand rounds for today. Thank you, everyone.
Thank you.
Goodbye now.